Membranoproliferative Glomerulonephritis. Membranoproliferative Glomerulonephritis (MPGN) is a rare pattern of glomerular injury characterized by immune complex deposition, complement activation, and mesangial cell proliferation. It leads to chronic inflammation and progressive glomerular damage. Membranoproliferative glomerulonephritis can occur idiopathically or secondary to other conditions such as chronic infections, autoimmune disease, or monoclonal gammopathy. Peak incidence. MPGN is rare, with an estimated prevalence of around 1 in 100,000 in the UK. It affects both sexes equally, with most cases presenting in children or young adults. Membranoproliferative glomerulonephritis is caused by immune complex deposition in the glomerular basement membrane and mesangium. This triggers complement activation, particularly via the classical and alternative pathways. Histologically, MPGN is classified into immune complex mediated MPGN, often secondary to hepatitis B, hepatitis C, autoimmune diseases, for example systemic lupus erythematosus, or malignancy, or complement-mediated MPGN due to dysregulation of the alternative complement pathway, for example C3 glomerulopathy. Symptoms. Many patients present insidiously with microscopic hematuria and proteinuria. Edema, especially periorbital and peripheral. Features of nephrotic syndrome: heavy proteinuria, hypoalbuminemia, hyperlipidemia, and edema. Features of nephritic syndrome: hematuria, hypertension, and reduced renal function. Signs: hypertension, edema, peripheral or generalized, and in advanced disease, signs of chronic kidney disease. Diagnosis. Diagnosis is suspected clinically and confirmed with renal biopsy. Investigations include urinalysis, which detects hematuria and proteinuria, urine microscopy, which may show red blood cells or casts, blood tests assessing renal function, albumin, lipid profile, and complement levels, C3 and C4, serology, screening for secondary causes such as hepatitis B, hepatitis C, HIV, and autoimmune diseases, renal biopsy. This confirms the diagnosis, showing mesangial proliferation, double contour, tram-track appearance of the glomerular basement membrane, and immune deposits. Genetic testing. This may be considered in suspected familial or complement-mediated disease. Complications: progressive chronic kidney disease, end-stage renal disease requiring dialysis or transplantation, recurrence disease after kidney transplantation, hypertension, nephrotic syndrome and its complications, for example thrombosis, infection, and hyperlipidemia, and adverse effects on long-term immunosuppression. Management. There is no curative treatment, and management focuses on slowing disease progression and treating the complications. Supportive therapy. Blood pressure control, usually with ACE inhibitors or angiotensin receptor blockers. Salt and fluid restriction, and statins for dyslipidemia. Immunosuppression. Corticosteroids may be considered in selected cases, particularly in children or those with nephrotic syndrome. Other immunosuppressants, for example cyclophosphamide, mycophenolate mofetil, and rituximab, may be used under specialist supervision. Secondary cause treatment. Antiviral therapy for hepatitis B or C if present. And management for autoimmune or hematological conditions. Renal replacement therapy. Dialysis or transplantation for end-stage disease. Recurrence in the transplanted kidney is common. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today